Welcome to the Alberta Transplant Institute rounds today. I'd just like to acknowledge that the University of Alberta is located on Treaty 6 territory and respects the histories, languages, and cultures of the First Nations, Métis, Inuit, and all First Peoples of Canada, whose presence continues to enrich our vibrant community. I would also like to thank Plaiden for the support of the ATI seminar series, and just a reminder to register for the ATI Research Day held on June 20th to 21st of this year. Today, it's my pleasure to introduce Dr. Megan Mahoney, who is a pediatric intensivist, clinical assistant professor, and SEND physician in Calgary. Her interest in advocacy in pediatric organ and tissue donation led her to taking on the role of medical lead for a national initiative to optimize pediatric organ donation with Canadian Blood Services. Her main areas of interest are donor family support and outreach and education, particularly for school-aged children. With that, I would like to welcome Dr. Mahoney to share her screen and begin her presentation. Thank you.
Great. Thanks so much for having me. It's always a pleasure. I tell our residents I could talk about this forever. So keeping it down to a broad overview and 45 minutes ish is a bit of a challenge for me. So happy to take questions at the end and hopefully a bit of discussion. Oops, it's not. There we go. In terms of conflicts of interests, really the only affiliation that I have outside of the hospital is with Canadian Blood Services, with whom I've been working on coming up with some strategies to optimize pediatric organ donation in Canada, and they've generously financially supported some of the QI initiatives that we've undertaken in the last couple of years. I thought I'd start by explaining a bit about where I'm coming from and why, how I ended up working in this area. I'm a pediatric intensivist, so work with patients on the transplant list. We do kidney transplants at the Alberta Children's Hospital, but in my training, different transplants centers along the way. But really my interest comes from the donation side almost exclusively. What I've said to our residents before is the fact that a patient or many patients will benefit from a life-saving organ transplant is fantastic. And of really obviously the point of organ donation overall. But for me, as a practitioner, for me, I'm in this for the families that are losing a child at the bedside when I can offer nothing else to save the life of their child. This is possibly something I can offer to a family at the end of their child's life to help them going forward. And really that's come from experiences with families along the way. I had a particularly poignant, memorable experience with a family of a little girl who died a long time ago now. Her name was Mackenzie, and tragic scenario, as they all are, that impacted us all. And several years later, I was stopped by her mother at a shopping mall, who recognized me and remembered me, and told me about her experience in grief since the death of her daughter, and asked me point blank if there was anything she could do to contribute to the organ donation community, because she really felt that was what was the game changer for her in her grieving process, and provided hope where she didn't think that there could ever be hope again. The idea that Mackenzie was still out there helping people, saving lives, and having other people live life to their fullest was really what got her up off the floor when she needed it most. And I had never heard a family say that before, because one of the unique aspects of critical care is that we often don't see these families after the fact, whether the children have survived and gone on to live full lives, or whether the children have passed and families then leave our walls. We don't often connect with them again. And so to hear the impact that organ donation had on this family was surprising to me and quite striking. And so I looked into opportunities. I had been involved a little bit, but really that kickstarted my journey in organ and tissue donation, and really my advocacy for families at the end of life to have access to this potentially life-altering intervention at the end. And so again, for me, these stories that have come back year after year from families that have been impacted by the act of donation, not just life-saving transplants, but the act of donation really transformed their experience and the legacy that their child leaves in the world. So it's undeniable, pediatric organ donation is a rare event. And these are some reasonably recent data from CIHI looking at adult organ donation and transplant rates, or sorry, wait lists. And if you compare and contrast that to the pediatric donation rate and wait list, the numbers are orders of magnitude lower. And, you know, that's not surprising for many reasons. But, you know, the other trend that is quite noticeable, I think, when I look at these data is that the adult donor rate or number of adult donors is almost consistently increasing. Whereas the pediatric donor numbers are all over the place and not a consistent rate of increase. And this isn't just Canada. This is a trend. These are trends that are seen all over the world. These are data from the UK, looking at deceased donors in the light blue. Again, they're in the tens. Numbers are in the tens as opposed to hundreds or thousands for an entire country, which is important, not only because it means there are very few donors, but really highlighting the idea that every opportunity is critically important when the numbers are so low, especially in comparison to the transplant list. Matt Weiss, I have learned since, has made a valiant attempt in contrasting and comparing some of the numbers internationally for pediatric donors, and you'll notice that Canada is not on this graph. I will explain a little bit later why I have come to understand why that was so hard to get those numbers. But really looking at how low these numbers are. These are total donors, NDD and DCD, the UK, Spain, and the US. Obviously the US, quite a different graph for a number of reasons, but the numbers are strikingly low. And then in looking at what is traditionally the metric for donation rates, certainly in the adult population, the donors per million population, based on age group. If you look at the differences there in the donors per million, even in UK, which is the lowest in comparatively of these three countries at 14 per million population, the pediatric rate there is 2.4. Looking at that's brain death or DCD, also again, the numbers strikingly, shockingly a lot lower than the adult donation numbers. Again, you know, calling a lot of people, me included, are considering what the most appropriate, most useful way of looking at donor rates is. Donors per million population is a tricky one because of mortality rates not being figured into that and causes of death. So again, looking at, I think going forward, a lot of numbers will change in looking at, you know, ventilated deaths as opposed to donors per million population. But I think the most important thing really is that this is a rare event in general. It's a rare, as comparatively, it's also very rare. And why is that? I mean, there are some things that are fairly obvious. Pediatric mortality is low. That's a good thing. The diagnosis of pediatric brain death, or the diagnosis of brain death in pediatrics, is a complicated endeavor. I often will quiz our residents on NDD diagnosis in kids because the guidelines are mind-blowingly complicated and favorite exam questions because they're age dependent and the time frames and minimum clinical criteria differ based on age. and neonatal brain death diagnosis is even more complicated. And so that adds an extra layer of complexity, intimidation, work, expertise that's required for these diagnoses, and can all contribute to the lower donation rates as well. Pediatric DCD worldwide is quite a bit behind adult DCD. And the uptake of that has been a lot slower. I think we're moving along, but has definitely been a slower process. Pediatric organs can be technically challenging to transplant, and pediatric patients can be technically challenging to transplant them into. And so our acceptance criteria and allocation criteria are also complex and add to the challenges in organ acceptance. Approaching a family to ask for organs at the end of a child's life is terrifying to a lot of people, understandably so. It's a situation that nobody wants to be in on any side of the bed. And so it can often be challenging and can lead to a lack of approach. I think consent rates in pediatrics are lower. We don't know in Canada yet, really, sort of, we don't have those data very robustly, let's say, but certainly it's a barrier. So the pediatric mortality and NDD diagnosis I thought I would sort of leave as either too complicated to talk about or a bit self-explanatory, depending on which one we're looking at. But I'll go through the rest of those reasons in a bit more detail. Pediatric DCD, as I said, has lagged behind adult DCD, as in everything. As a pediatric intensivist, I know that everything gets tested and done in adults first, and then there is some degree of uptake along the way in the pediatric population, whether it's without being studied as robustly or just studied later. And so this isn't something new to anyone who works in peds, that we tend to come second or after, I guess, practices in the adult critical care world usually. This again is from Matt Weiss's comparative paper looking at DCD, percentage of DCD patients as they make up the total population of actual donors. They're quite low, and I spent some time working in Spain, which is well known as being one of the pioneers and leaders in organ donation in the world. And yet I was quite surprised when I got there to learn that they did not do DCD in children when I was there. Certainly they didn't in Barcelona. And so for even a world leader in DCD, controlled and uncontrolled DCD, the uptake in pediatrics was way, way behind. And so we see that again. These are data from Australia, New Zealand. Same thing, looking at the percentage that DCD contributes to donation is quite low. And to try and help with that, again, uptake has been an issue, and we see that in the Canadian landscape as well. We have 16 PICUs in Canada, and not all of the PICUs in Canada have DCD programs yet. And most adult ICUs have had DCD underway since 2006, 2008, and ongoing. And ours has been, pediatric experience has been a lot slower. And so to help with that, Matt Weiss led the only, as far as we know, the only pediatric guidelines out there for DCD. And they're evidence-based, and hopefully the goal was to help the rollout of DCD nationally, but also support other places. As we, again, the rarity of this event means that we have to share experience, and practice, hands-on practice is rare. In terms of size, I was going to say any pediatric intensivist can tell you that certainly the neonatal experience reflects the fact that not all potential donors are accepted for donation by the transplant centers themselves because of challenges with size. Size for transplantation, but also size for organ recovery. And that's a shame for so many reasons. But also, if you look at this, the opportunity for potential donors, the ICU deaths, the proportion of children that are dying in ICUs is much higher in the younger age group. If you look at the line as deaths in ICUs, and the bars are organ donors. And so they're a flipped image of one another, that the distribution reflects that younger kids are more likely to die in ICU, but the older kids are more likely to be donors. Some of that is a reflection of consent, but also some of that is a reflection of the fact that in infants, even if they are potential donors, families who are motivated to donate, I have often had the experience of having to say to families, thank you. There isn't an opportunity for organ donation based on the size of the baby, and we'll talk about tissue donation. And so there are many opportunities there for exploring potential. And then within the allocation discussion, or within the acceptance discussion, organ acceptance discussion, comes the discussion of organ allocation. And this was news to me when I got into this field and began to explore that. And it's often quite surprising to families to understand that if their child becomes an organ donor, that more often than not, their organs will be transplanted into adult patients. Certainly, that's the experience for kidney and liver. And these are data from UNOS in the United States, looking at the number of organs, pediatric organs that are transplanted into adult recipients versus pediatric recipients. And I also didn't really understand that I'd never occurred to me that that would be something that would be important to a family at the time of donation. And I've learned over the years that families are often quietly disappointed to hear that organs may not go to other children. And so I've actually made that a practice in explaining that, so that there isn't a disappointment that comes after the fact when they receive a thank you letter or are reached out to by recipient families down the road, a bit of a warning shot that their organs, the child's organs, may end up being transplanted into adults. You can see that these numbers that are declining, the adult transplants versus the pediatric transplants. The pediatric proportion is increasing over this time frame here. This is a reflection, UNOS and the organ sharing organizations had changed their criteria for allocation, and so that these data reflect that. It's also really important to mention that, the other big reason for this, of course, is that there are more adults on the wait list than there are children on the wait list, which is a good thing. And I've also had to say to families in the past that, thank you for your commitment and motivation for your child to be an organ donor. But fortunately, there are no children on the wait list that are in need of organs this size. And I have sort of refined how I say that over the years, but sometimes that is again a positive way of explaining why this child can't be an organ donor based on size. There are no babies waiting for kidneys. There are no babies waiting for livers, and that's part of the reason. And a lot of, again, the proportion of adults that receive pediatric organs. It's also important to remember that when those adults receive those transplants, they are taken off the wait list, which then will provide or bumps the kids up higher up on those wait lists too. So any chipping away at a wait list, whether it's an adult patient or a pediatric patient, is a good thing. I find these data and this idea quite surprising, and it's not something that I really appreciated when I was starting out. The family approach and consent in pediatrics is, I have learned, that is something that is different, I think, and often will make people uncomfortable, pediatric practitioners and donor coordinators who may not have much experience at the children's hospitals or approaching families. The idea of losing a child is always a tragedy, and is never ever okay, and often brings people bring their own experience and their own fears and sadness and emotion to these conversations, which can be a really great thing, but also can lead to some barriers in approaching families. These are data from the UK, looking at approach rates. And we know that there are missed donor opportunities across the board. We know there are times when families aren't approached for a variety of reasons. In pediatrics, same thing happens. And you can see, the light blue bars are times when families were not approached. These are the x-axis are individual hospitals that are represented there. So you can see quite a variety. And there are other studies that describe that as well, that some places are really comfortable with this, some places aren't. Some donation organizations have more training in pediatric conversations, some have less. And so comfort seems to play into approach rates for families. And the reasons that are documented are listed here. This is, again, the same study. These are UK data. And one of the other unique factors, I think, in pediatric donation and barriers to donation is that one of our most common causes of death or of brain death, certainly in pediatric ICUs, is a result of trauma or child abuse or suspected child abuse, which means that the medical examiner or the coroner has a very big role in the decision making, I suppose, around what is and isn't okay after death. I'm thrilled to say that in Southern Alberta, our ODO is immensely supportive of the pediatric staff and of the families who are motivated to donate. And I can say that in recent memory, we've had a number of times where the medical examiner has refused to allow donation at the end of life. And every time our ODO, our medical director, has been able to have conversations with the examiner's office and reverse that decision with certain restrictions every time. But it takes time, it takes work, and it takes trust and understanding that taking no for an answer on the first pass isn't necessary, and to make a second phone call to the ODO or the donation physician. It takes a little bit of extra time and work, but it is an important barrier in pediatrics for sure. And then it's, the not identified as a potential donor or not suitable for donation is another misconception in peds. We're used to restrictions based on weight, based on size, based on age. And so a lot of those detailed restrictions that change all the time, to be honest, lead to people maybe making assumptions about suitability for donation at the bedside before looking further or getting more information. And then a lot of the time, of course, things aren't documented. whether it's an assumption about a family's cultural background, religious background, or how upset they are. Sometimes it's just easier or feels better not to. This is a recent study, just in 2021. It's a retrospective chart review in the United States. And this blew me away because the consent rates, this is looking at what factors contribute to likelihood of organ donation in pediatrics. But the consent piece of this really jumped out at me. These are just simply brain death diagnoses. So this isn't DCD, this is just NDD. Their approach rate, 93%, it's amazing. Consent rate, almost 75%, which I thought I had read wrong, to be honest. I'll go into this a little bit later, but we are currently looking into what our national pediatric consent rates are. We don't have those numbers accurately, but I will be gobsmacked if they are that high. I was actually just chatting with a colleague last week, expressing my opinion, I guess, or my experience. I think that our consent rate is declining recently. In my experience, I feel like consents are more and more challenging, and we've had fewer families consent, certainly after brain death and DCD, probably in our experience in our unit. And I'm interested to see what our data show. But the other thing that was interesting about this is that the most studies, when you look at pediatric donation rates or consent rates or approach rates, they don't usually mention the registries. And this one, I again thought I had read it wrong, or I had misunderstood the inclusion criteria, because they do mention registered organ donors here, which were excluded from the rest of their analysis, because the authors described that consent rates, if adolescents had been registered as organ donors, that would unduly influence the parents' decisions in favor of organ donation. And so they felt that would not contribute to understanding other factors. So they were eventually excluded from the analysis, which I thought was fascinating, because understanding a loved one's intent, as we know from the adult literature, understanding a loved one's intent with respect to organ and tissue donation is the most important factor in making a decision for your loved one. And often, because kids can't go on and register in general, some places you can at 16, some places in 18. But since kids don't register, checking the registry isn't something we do in Alberta. And boy, wouldn't it be neat to know that your child, what your child's intent was, whether it was a teenager or an older child, a mature child who had a conversation with you. That it's not something that's typically reflected in the pediatric literature. So it was nice to see it here. The other thing that this study showed is that in their study, pediatric donation or consent for pediatric donation is declining. Now this is a pretty dramatic looking decline. But when you look at the y-axis, they're starting out pretty high, again, in the high 70s for a consent rate, and still staying into the 70s as the rates have dropped over the time frame that the study was ongoing. The reasons for that weren't explored necessarily. The main point of this study was to look at differences across ODOs to see if there are regional or training related or experiential related factors that could be used to help improve consent rates. So again, mentioning that the number one reason or the number one factor in the adult literature, and in some respects in the pediatric literature, but certainly on the adult side, understanding what your loved one's intent was is the is the number one contributor to consent for organ or tissue donation. If somebody is registered, if somebody has shared their wishes, it makes it a lot simpler to know as the substitute decision maker what to do. In pediatrics, though, most people haven't had that conversation with their children or with their adolescents. What I can say, though, is that some of the most impactful, most motivated families in my donation experience have been motivated by the fact that they knew this is what their child would have wanted. In fact, our very first DCD case at our hospital here in Calgary was before our DCD program was officially up and running. This family asked about donation opportunities around DCD. At the end of life, we told them we didn't do that yet. And they would not take no for an answer because their daughter, who was 9, had a conversation with them at the dinner table after seeing a commercial on TV several weeks before. And they knew that this is absolutely what she wanted, and we're not going to rest until they could explore all options. And so we did. And it's families like this that push us to make things happen. And so we did. We put our pedal, what do you call it? We put our foot down, and we advanced and accelerated our preparation, and were able to facilitate DCD for this family. But most of the time, most often, families haven't talked about this. They haven't talked about it. Parents haven't talked about it with each other, and certainly very rare to have spoken about it with their children. But we do know that education around organ donation and transplantation, even in very young children, is a good thing. These are studies out of Scandinavia, but the gist of this this team's work is that conversations around organ donation aren't harmful. They're not scary if done right, or done in a sensitive way. Kids are resilient, kids are curious, and that often these conversations or these modules or this education at school will lead to children going home and having a conversation with their families at the dinner table or at somewhere at home. And the spin-off from that could be exponential. If you can imagine with me that a young child comes home, has a conversation about what they learned at school that day, and that leads to a conversation as a family, which then maybe leads to conversations as parents after the kids have gone to bed about what our wishes would be for each other, for our families, and the spin-offs could be quite impactful. I came to believe this without a doubt when I watched a documentary. The Nature of Things did a documentary on organ donation in Alberta, the Alberta hospital. And I sat down to watch it, and my son, who was he was in grade 2 at the time, wanted to watch it with me. And I was a bit worried. I didn't know how easy it would be, how gory it would be. People are going to die. It was about DCD. There was going to be ICUs there. I didn't know how to handle that, but he sat down with me and watched it. And watching his face when he understood the idea that this person has died, and this person, now this baby, is going to get a new heart because of this, is watching his face as he realized this was a thing, that this was possible, that putting a heart into somebody else to save their life was something that was real, not just a robot cartoon idea, but that was real. He just thought that was the most magical thing he had ever heard in his life. And that led to many conversations about transplant and about donation and about what I do. And it was remarkable and a really important learning experience for me about the magic of curiosity in children, and how that light in his eyes makes it less scary for me to talk about donation and to him. And so the opportunity that can present really has lit, which it was mentioned in the introduction, my area of interest and passion is talking to kids about this, talking to families about this, and trying to make it less scary, and to really zone in on that enthusiasm and the magic of this is a real thing that happens. It's not an opinion, it's not a myth, it's not a religious practice. This is a real thing. Transplant is this magical thing. And look what it can do. And so capitalizing on that really has been one of my favorite parts of my work in the donation world. I'll talk a bit about that again at the end. And in understanding the family approach and consent process, it's important for us to try and get have an understanding of what it is families need from us at this time. What do they want from us? So much of the hesitation and descriptions in the literature around reasons for not approach are about trying to protect these people. It's not that nobody's trying to hurt these families at the end of their child's life. We're trying to protect them. And sometimes not approaching a family is out of pure concern and love that it would hurt them. It would make things worse. And so it's really important for us to understand what it is that they need from us in those moments, and how to help work within that, and still provide them with the opportunity that is their right to have an opportunity to donate. And there are lots of studies that look about this in general, but also a few studies that look about it from the parental experience after the loss of a child. And really looking at these studies, the themes that come out are not surprising. Families describe that at the end of their child's life, they want something good to come from tragedy. They want hope. They talk about creating a legacy that part of their child will live on and do something really spectacular by saving lives. They talk about wanting to spare other parents, other families, the pain that they are experiencing while they're losing their child. They don't want anyone else to go through that. They want their child's death to prevent another parent from losing a child, and they can do that through transplant. Sometimes they talk about honoring a child's preference or wish. Often it's in broad terms, like he was so good at sharing, or she was such a kind, giving child. I'm sure she would have wanted this. They also, though, talk about the instinct of protecting their child, and we hear themes. We hear quotes like, "I wish I could. I wish we could say yes, but I just can't put him through anything else. He's been through so much already. We just can't put him through this. So we can't have his body go through anymore." They talk about the importance of trusting the team, knowing that the team has their best interest and their child's best interests at heart, and that we can communicate that to them very sensitively. And for me, when I approach a family to talk about donation opportunities, I have found that to be something that has become easier and easier over time, because I know that I believe that I am offering this family something I think could be helpful for them. I'm not asking them for anything. I'm not asking them to consider donation to save another child's life. I truly believe that for a lot of people, this is a therapeutic intervention I can offer that may provide hope for them in the days to come. When the grief is unbearable, maybe this is something that might help down the road. And I believe that. And so my sensitive communication and my communication to a family is coming entirely from that place. And I think that has certainly helped me in resisting tiptoeing around or apologetically having a conversation around donation, because I think it is my job to help this family. And so a little bit quickly about what we've been working on or trying to work on through the pandemic. Conflicting priorities, let's say. I have been really, really lucky to have partnered with Canadian Blood Services or entrusted by Canadian Blood Services to help with this national pediatric and neonatal initiative to optimize pediatric donation in Canada. And I'm also been super lucky to be a part of a multidisciplinary group that is Western Canadian based, which is also pretty unusual for the donation community in Canada, that we are all based in Vancouver and Calgary. So myself, Lori Lee is one of our critical care nurse practitioners here at the Children's Hospital. Dr. Himuka is a pediatric transplant nephrologist here at our hospital in Calgary. Lee James is a CBS project manager. She's in Vancouver, and Dorianne is our research coordinator here in Calgary. And together we've been working with Canadian Blood Services to strategize. And part of that has been information gathering. And this is, again, I will save my rant for another day about how hard this has been in the climate of COVID. There's been a few delays in getting this information, but first steps we thought were to gather information. Information is lacking around the pediatric donation programs, services, experience, and actual rates and hard data. So first thing that Lori undertook was a massive survey of the pediatric transplant programs across the country, all the ODOs across the country, the PICUs are across the country, and the NICUs, looking at who's doing what, who has a DCD program, who has a donation physician, what kind of supports these facilities have, what kind of training the coordinators have around pediatrics. Also starting to chip away a little bit at the organ acceptance criteria that the transplant centers across the country have, how allocation is done, and to really try and centralize some of those data. So we have those data now. We're just in the process of analyzing those and hopefully getting the information out and in a format to be acted upon. And then I have undertaken the pediatric potential donor audit across the PICUs and some NICUs in the country, really getting down to a chart level audit of potential donors, reasons for approach, non-approach, looking at consent rates, really also trying to get a sense of what our neonatal donor potential is. That this has really been challenging, certainly over the pandemic, but we're pretty much underway now in gathering this information to try and have these be our starting blocks for hopefully intervention and support across the country. Hoping to use these data for collaboration. We've already had a couple of pediatric priorities meetings with experts and stakeholders across the country, looking at trying to network with the clinicians on the ground, so PICUs and NICUs. Again, these being such rare opportunities for us, it's really important for us to be able to work with each other's experience and share challenges and share protocols, share guidelines, share experience. And when you have one or maybe two donors a year for a DCD program or fewer, it's important to be able to learn from other people's experiences as well and stay up to date and stay well trained. It's also important for us to share these stories that help to motivate us when, again, with one donor a year in a DCD program, it's hard to stay motivated sometimes to keep that program up and running and people skilled. Sharing stories and family experiences helps with that. Trying to really work together with our NICU colleagues who have an even smaller donor pool than we do, and these opportunities are even more rare for them. So trying to strengthen partnerships to enable donation in the infant population where possible. Alberta now has 2 pediatric donation physicians, or SEND physicians as they're called here, which has also been fantastic to have support for pediatric roles within the province has been super helpful. We're also looking to expand pediatric or family specific resources for the medical community, training opportunities for donor coordinators, and then looking at education for families, teachers, kids. As I said before, an area that's close to my heart of normalizing these conversations with families, getting rid of some myths and telling stories, sharing stories to support these conversations. I've also been super fortunate to have connected with the Jenny Ryan at Canadian Blood Services, who has put me in touch with a number of other people who are also interested in education geared toward families and children. Dr. Wall has built programs in high school education and curriculum, and Jenny has spearheaded a education portal, which I'll show you briefly, through CBS, that has age appropriate, age filtered and organized resources for teachers, for families, and for kids, all in one spot, which is, I think, fabulous. I've also been put in touch and connected with other like-minded, enthusiastic advocates, the Boulay family being one of them. Bernadine Boulay is a grade 2 teacher. She's Logan Boulay's mom, who was a organ donor after the Humboldt bus crash in 2018. And Bernie was challenged by trying to find resources for her students, her grade 2 students, when she was trying to involve them in Green Shirt Day, and couldn't find anything Canadian at all. And so found the Orgamites, which I'll show you, which have subsequently now been adapted by through Canadian Blood Services and adapted for Canadian audiences. And tons of educational material has come out of that collaboration. The 5 of us here, transplant recipients, Transplant Association coordinators, Jenny Wichard is a pharmacist, and myself, Bernie, a teacher. We all collaborated and were able to speak at 2 different events at teachers' conventions this past year, and hope to do more to help facilitate and normalize conversations and show some of these resources to teachers around the province in anticipation of Green Shirt Day, making that an opportunity for education in the elementary school population specifically. And these are the Orgamites. It's a creation out of the UK. And like I said, has been adapted for Canadian audiences. And my absolute favorite thing is bottom right corner there is the Orgamites on Green Shirt Day. And this is the Canadian website here, where there are fabulous resources, learning about what the organs do, talking about transplants, videos, animations, how to talk to kids about organ donation, just a wealth of information. And it can also be accessed here through, this is the learning or education portal I was talking about that Canadian Blood Services has put together. And you can see this is just a screenshot, but at that website, broken down into resources for teachers, students, parents, and it is all broken down. You can search by grade level, and it goes from multimedia to book recommendations to activities and other links. It's quite fantastic. So hopefully that will lead to a few more, a bit more uptake, and having all those resources in one place it's been fantastic and such a fun project to participate in. Again, I can talk about that. That's the part I could talk about forever. So I'll try and wrap up a little bit and leave maybe a bit of time for some questions. I hope I have really driven home that while it's a rare opportunity, pediatric organ donation is impactful, both for the grieving donor family, but also for both kids and adults waiting for transplant. And so because it's so rare, it is, I think, absolutely critical that every donor opportunity be explored, because it doesn't happen very often. The patients and families have a right to this information, and it's my job to make sure they get it. And again, like I said, I believe firmly that it is something I can offer to my patients' families at the end of their life that could be helpful. And that we're behind. And again, that for us in peds, that's not a new feeling. We're often a couple of steps behind. I'm really hopeful that it's catching up. DCD uptake at a program level is coming, and us sort of uniting together and being able to talk about this a bit more easily, I'm hoping will change things and catch us up. These are just a couple of quotes. Again, I collect them, quotes from some of our families after organ and tissue donation in our hospital.
Thanks, Dr. Mahoney. That was a tremendous presentation, and you can tell you're impassioned about what you do. I have a question about, you had mentioned consent rates not being, the information not being available between pediatric and adult, and that was my question actually. But what do you think could be improved across the country in Alberta in terms of that referral pathway consent process? Is that we're making great strides with our SEND program and the education that's happening, and that's all very exciting. And just wondered if there's extra thoughts, because I know you've got international experience and perspective on that.
I guess, yeah, a couple of things. I think the pediatric SEND physician role certainly has been it's been a really good thing. So I have been pretty involved before the SEND physician role at our hospital, but now really that's been formalized. And so one of the things I think that's helped is that we've had a couple of instances where consent has been a bit challenging, or families have had specific questions about the end of life process, or there have been a couple of hiccups or bumps where because it's me that they're going to call, that the donor coordinators will connect with, and that I'm already involved as a SEND physician, formally involved with these families, it's been a lot more smooth in being able to jump in and provide my own experience around that. Whereas the donor coordinators, if it's rare for me to do a donor conversation, it's exceedingly rare for them. And so to be able to collaborate on those consent conversations has led to a couple of consents that we wouldn't have gotten otherwise had we not worked together. So I think that has been a huge improvement. I also, my own opinion, I also think that the presumed consent debate or idea takes the pressure off, or mandatory referral even will take the pressure off the frontline practitioners. If we don't have to make the decision about suitability, if it is absolutely mandated that everybody gets referred, if it is absolutely mandated that, again, presumed consent in pediatrics, that won't be a thing, but at least it's a culture shift in that it's a knee-jerk phone call every time. And I trained in Ontario under the mandatory referral, and with every death determination, I had to write down the Trillium Gift of Life case number on the death form every time. So I think that just takes the pressure off the, I'm not sure, will I hurt them? I don't want to do harm. If it's not a question, then it makes that a little bit simpler, I think. It's not quite that simple, but that's sort of my take on it.
Great, thanks.
Great, thank you.
Next, we have Murray Wilson. Murray, are you there? I'll just ask his question from the chat then. So, Dr. Mahoney, what is your advice to policymakers? And so, Dr. Mahoney, what is your advice to improve things in Calgary, Edmonton, and the whole of Alberta for policymakers?
I guess it would be what I just said. Yeah, I think the SEND physician and support on the ground was a huge, big step. And then I do think that the idea of some degree of mandatory referral or whatever that looks like, I think would be helpful for the frontline practitioners. I do.
Thanks. Now we'll go to Lori. Lori West.
Thanks very much, Rex. Megan, that was just amazing work, and I applaud you again. And I'm also proud of the fact that pediatric intensivists for the last, have really done amazing work in this area for the last, 30 years, really leading the way in donation research and donation practices around the world, especially Canadian pediatric physicians. My question was, when I go back to the hard work that you're doing and that you and your colleagues are doing and the difficulty of it, I know the mother that you opened your presentation with. I've come to work with her, and every time I think how hard this is, I just listen to her words about the profound sense of comfort that it has brought to her over the years. My specific question was something that you brought up in the study that you showed that actually showed that amazing high rate of consent, and the piece where it excluded those who had been on registries with, I thought you said something about the fact that it might unduly influence how the parents thought about the donation, and I'm kind of puzzled by that, because wouldn't that be the intent, actually?
Yeah, and so, but the point of the study was to look at factors that would most likely lead to consent, like what factors lead to families consenting for pediatric organ donation. And in general, pediatric patients aren't on the registry. So they were trying to exclude those to look at other factors like culture and ethnicity and region, and break it down by ODO to look at things that they could change. And I snicker a little bit in thinking, man, I think we should be able to have kids 12 and up put their, some sort of kid friendly version of that, right? That why can't a 12-year-old say, hey, you know what, I'm interested in this too, and lead to a conversation? But that's a dicey one, touchy one, I know. But I think that could help. And I think that it is a modifiable factor, even for kids.
Thank you very much. This is great work.
Okay, thanks, Lori. Elf.
Oh, hi, Megan. Hey, what a wonderful talk. And I really want to congratulate you on your holistic approach to the topic of pediatric and neonatal organ transplant. Most of us look at it sort of through a narrower lens, and this broad swath that you've taken certainly has educated me in a big way. Yeah, I just love the passion. One of the points that I'd like to reinforce, and you spoke to it nicely, is this concept of the send physicians. So having physicians in each of the centers where donors potentially can be identified, and opportunities to improve the system. I think that has made a big difference, and it's just starting to really be fruitful. That's the first thing. The second thing is, I think we need to recognize that sort of what we considered historical ineligibility for organs likely is going to change fairly dramatically in the next few years as the various different extracorporeal organ resuscitative systems come forth. That will affect the number of hearts that can be procured, the number of lungs, the livers, and potentially kidneys as well. And
DCD hearts is the other big one, right?
Absolutely. And so that gets to the neonatal conversation. I know that we've had some conversations recently in our center, and there are so few neonates that die neurologic deaths, but the opportunity for DCD certainly is there. So both in pediatrics and in neonates, I think that the role of DCD will be important. And so we have some process to go through. The adults are helping us in a big way with respect to showing us the way, but I think that is the next frontier. So again, thank you.
You have, Michael Van Manen at your home site there that is a leader in the neonatal DCD idea. And I say idea because it's so rare. I think there's been one maybe in neonatal DCD. Like, just doesn't happen because the organ acceptance criteria is so strict, and you have to have essentially like a 6 kilo per perfect baby, which they don't die, which is a good thing. But the idea of DCD hearts will be game changing in the NICU. And I think, every time we have a neonatal potential donor, our ODO gets a little frustrated with me a bit, because I still want to offer, and I still ask our donor coordinators we don't do a full consent process, but we'll do a call out for all the organs just to see, because you never know. And it gives us that practice and gives the neonatal team the message that this is important, and that when DCD hearts are a thing, that we've already got some groundwork done and collaborative effort done. And that was the main reason for including the NICUs in this potential donor audit, is to get a bit of a sense of how big of a group of patients is this, and what is the potential for neonatal heart donation when we're there, which we're not that far off, I don't think.
Great, thank you very much. That timing, it's 1 o'clock, and I'd like to thank Dr. Mahoney on behalf of the Alberta Transplant Institute for this excellent presentation that you've given us today, and thank you to all our participants and those that asked questions. Just a reminder that next week's seminar, we're very pleased to have a panel discussion on islet transplantation with Dr. James Shapiro, Dr. Patrick McDonald, and Kathleen Gibson, presenting the history and future of the clinical islet transplant program. With that, we would like to again finally thank Dr. Mahoney for this great talk, and wish everybody a great day. Thank you.